Welcome to the Healthy Matters Podcast with Dr. David Hilden, primary care physician and acute care hospitalist at Hennepin Healthcare in downtown Minneapolis, where we cover the latest in health, healthcare, and what matters to you. And now, here's our host.
Hey everyone, welcome to Healthy Matters Podcast, where we dive into the world of healthcare with experts who live it every day. You've probably figured out by now that I am not Dr. Hilden. He is on a well-deserved vacation. I am Megan McCoy, and I'm a PA in the ear, nose, and throat department here at Hennepin Healthcare. I've been on this show before, and so if you go back and listen to episode 7 of season 2, my voice may sound a little familiar. Today, we're going to dive into ear, nose, and throat conditions in children. And we have our guest today, Dr. Krishnan Subramaniam, who's a pediatrician here. He's also the chief medical officer at Hennepin Health. And we're going to talk about all of the things that go on in kids, from snot to strep throat, and we'll dive right into it. So thanks for being here, Dr. Krish.
Oh, thanks, Megan, for having me. Congratulations on your new chair. I plan on subscribing now, immediately.
All right, so let's get into it. Why don't we start with nose? Personally, my favorite. So, Dr. Krish, why do kids have an endless supply of snot? And I have a 5-year-old and a 2-year-old, and I promise we go through so many tissues. It's really the thing that keeps us at Costco. It's like the number of tissues we go through. So, what is up with that? Why?
Well, first, Megan, congratulations on your little ones. Second, I'm a little nervous, I'm not going to lie. You know, I deal with noses, ears, and throats a lot, but frankly, you're the expert, right? And I have referred many a patient over the years to Megan to get her assistance and her wisdom. So I feel like I'm in a test here. So I'm going to do my best to get, but no, I hope what we can bring today is just some practical advice, the things that we're seeing most commonly, things that we're seeing day in, day out, and then hopefully just some advice that will help calm some nerves, because it's a nerve-wracking time.
For sure.
The winter, the cold season, the viral season.
The quademic.
I get questions. It seems like my kids are sick all the time.
Right. And if they're in daycare, they are. They just
forget
are.
About it,
yeah.
Right? Like, forget about it.
Right.
They are sick all the time. And I think that kind of begins to answer your question. Why does it seem like kids have a ton of snot? One, it's because they do. There are studies that show that kids under 2 years of age in their first year of daycare are getting sick on average about once a month.
Yeah.
And when we'll talk about this a little bit more, but the average sickness is lasting you 10 to 14 days. That means half the time you are sick.
Mm-hmm.
And most of these sicknesses produce a lot of mucus.
Mm-hmm.
You have kids who don't have a really built-up immune system, so they're trying to rev up. They're trying to fight these infections, trying to build a lot of mucus. And then I think the other thing that makes it tough is that, Megan, when you and I get a cold, when we get snot, we have bigger airways, we have bigger noses, we have bigger mouths. And so the mucus, we have more space to put the mucus. Whereas when your 2-year-old or my 3-year-old get mucus, it clogs up 50% of their airway.
Right, it's so little.
And it's tough to breathe through a 50% airway.
Right.
And I think that's why it becomes so noticeable to families, to parents, and that's why it causes us a lot of grief.
Yeah, I think you're right. Daycare is just the worst. It's great. We love our daycare providers. I am so thankful for being able to send my kids to daycare, but it does feel like they're sick all the time.
Yeah, and I think a lot of what we have to do is set expectations for families, including ourselves, right? To understand, that first year and a half, it is a lot of sickness with great frequency. What you'll notice as the patterning goes on is that as they build up immunity to these illnesses, starting about year 3 or 4, those kids who have been through daycare have that built-up immune system, and they actually, you may see sickness actually get less.
Yep.
And so there is a light at the end of the tunnel.
For sure.
The light comes along with a lot of good learning about how to eat civilly at a table and how to potty train, right?
Right.
Like, there's positive things to be learned.
Right.
But it's a tough year and a half, and we parents get to share the germs too, right?
Yeah.
We get sick
Yes.
too, and it's hard.
Yeah, I feel like I didn't get sick for decades until I had kids, and now it gets me too. So when you're seeing kids, at what point do you decide, you know what, this is abnormal snot, this is abnormal mucus, this is an atypical number of illnesses or sicknesses, and I think you need to go see ENT? At what point do you sort of make that decision as a pediatrician?
So I think first, for us to know that there is this expected 12 to 13 illnesses, there's that average of 10 to 14 days. When we start to get worried is when we start to see a few different symptoms. If I see a kid having, fever for that whole prolonged period of time, I'm like, that's not normal.
Sure.
A few days of fever, sure. But having that prolonged fever, I get a little concerned. I think if the cold is getting worse, like colds should have a couple days of badness and then get better.
Yeah.
Like that's the general arc of a cold.
Totally.
If I see getting actively worse. The fever's now beginning on day 6 and starting to get worse. If the mucus production is getting worse. And then if a child is in a lot of pain, right? If you're having a lot of pain in your sinus areas, which, and we can go into that, but like the sinuses are spaces that exist behind your nose, kind of in your face area. If kids are having pain in their face or around the nose area, that's not usual.
Sure.
And so if I see that progression, I start to think, does this child have a sinus infection? Do they have something else going on? And then, we may do some conservative management. We may do some antibiotics. And if that's still not getting better, then boy, Megan, we're going to call you.
Yeah. Great. The other thing I think we'd be remiss if we didn't talk about when it comes to snot and runny noses is kids who put stuff in their nose, which is a big part of my practice. And, one of the telltale signs of something stuck in the nose, and you as a pediatrician know this, is if you have a kid with snot coming out of just one side of the nose and it smells gross, be super suspicious of something up there.
And that foreign object. Boy, kids are really good at hiding things.
Oh, man.
And the nose is a great place to do that. So thanks for bringing that up. Yeah, if you're smelling that foul smell, sometimes I'll hear parents or children say, hey, I have really bad breath.
Yes.
It'll come across as a bad breath.
Yes,
type of
also
feeling.
known as halitosis, for sure.
And so when that happens and you're having like a lot of mucus production and it's new, then it's something we should definitely look and then frequently we'll ask our ENT colleagues to go up there with their fancy tools and get it out.
And that is what we do.
Yes.
And, sometimes we're successful and sometimes it takes a little bit of anesthesia in the operating room to get it out, but always happy to see those kids. And that's something that if you're worried, something that should be done right away. We don't want that thing sitting in there for a long time. Let's switch gears and move on to ears. If you want to walk through ear infections, ear canal infections, middle ear infections, and how you take care of them, and then at what point you send them to ENT.
One of the most common complaints we get is my child's ear is hurting them. They're in pain. They're in discomfort.
They're pulling at it. Yeah.
It's really common. I had the misfortune of having some sort of ear pain infection a few years ago, and they're really painful.
As an adult. Yeah.
As an adult, they are really painful. And I'm like, how do the little kids deal with this? Right. And so there's a reason. It captures the attention of a family.
Yeah.
And I think it's really important for us to honor that and recognize that if a child's waking up screaming a few times a night due to this pain, it's awful.
Yeah.
It's awful for the whole family. Taking a step back, what is an ear infection? I think the classic ear infection we think about is something we call an otitis media. It's a middle ear infection. We all have these tubes in our face, in our head. They connect our nasal area to our ear, and they're called the eustachian tubes. And they allow mucus and snot to flow around. They allow fluid to flow. And what happens in kids is that just the way the faces are built, those become a lot flatter as opposed to angled. You don't have gravity helping you as much. And what that allows is mucus to get stuck a little bit more.
Yep.
Also, back to our whole idea, kids have small passageways. So it's really easy to get that clogged up or inflamed. And then what happens thereafter is that mucus, pus, white blood cells, snot, all sorts of things can get caught in the middle ear.
Yep.
If you imagine that the middle ear is a little chamber and you start to pack it full of fluid, you're going to start pushing on the one end that's a little bit flexible, and that's your eardrum. And that is where kids begin to have a lot of pain.
And it's so sensitive. That eardrum is so sensitive, full of nerves.
Yes.
And that's why it's so painful, yeah.
And so you see these poor children who are like, it hurts, it's painful. When we talk about the classic ear infection, that's what we're treating. And this is the reason why kids, small kids in particular, get ear infections and get them with some frequency.
It's the anatomy.
It's the anatomy. And so, part of the reason, Megan, that you probably don't treat a ton of ear infections, at least at first pass, is because we see a lot of kids under the age of 2, right? And so when we start thinking about when do we treat an ear infection, one of the key guidelines is how old is the child?
Exactly.
If they're under 2 years of age, we're much more likely to do a course of antibiotics because, well, one, the kid can't communicate with us as well to know when things are getting worse. But also, once they get past 2, the likelihood that gravity, size, and space will help improve its situation on its own is much higher.
Yes.
Whereas with a under 2-year-old, it may not get as well as quickly.
For sure. So let's talk about, the kids who get a lot of otitis media or middle ear infections. At what point are like, I've treated this kid with 4 or 5 rounds of antibiotics and they're getting better, but they just keep getting these ear infections. I think maybe it's time to call ENT.
So we'll walk down a stepwise process with families. And, if it's 1 day of pain and no fever, we probably won't walk down an antibiotic pathway. But if we start, treating your child with the first line medicine, which is usually amoxicillin, we'll treat the child, and most of the time, 90+ % of the time, it gets better. But we have a couple other antibiotics in our back pocket that if things are not getting well as quickly, we may transition to a different antibiotic. We may try even a third antibiotic. So we want kids to start to feel better, both from a pain perspective. We want that fever to come down. Frankly, at baseline, we want families to start to sleep again a little bit more.
Yeah, right.
So that's how we would begin the first approach. Now, we see those kids, and frequently it has to do with the anatomy. There's a genetic component to the anatomy.
Sure is.
There's a familial component to the anatomy, and you'll see some kids who just have tubes that get clogged up.
Yep.
And when that happens over and over again, if I see over 4 in 1 year, and there's other numbers, like if you see 7 or 8 in 2 years and 10 in 3 years. But basically, once I start to see you 4 times for an ear infection, I'm going to say, you know what? Here, I want you to make an appointment with the ENT. Mm-hmm. Maybe over the course of the next month, maybe it gets better and everything is perfect. Great. But at least you have that appointment. And then when you go see the ENT doctors, you can discuss whether there's benefit to doing something further. And usually that something further is something that you're an expert in, Megan, and something we're really grateful to have you all around for, which is placing some tubes so that you have a release valve for all this pus.
Exactly.
And so when we start to see you coming back over and over again, when we start to see that look in the eyes of parents where we're done.
Yeah.
This is 10.
Please do something else besides an antibiotic.
Dr. Krish, we like you. We don't like you this much,
exactly.
right? And you don't want any, we want to make sure families are okay.
Yeah.
And so we'll send them to our colleagues, and then you all do magical work with them and really can make a quality of life way better for families.
I will say tubes are a wonderful thing that we have the ability to do. Just real quick, we take children to the operating room. We do give them general anesthesia, but it takes about 5 minutes. It is so fast. All we do is make a very small hole in the eardrum. We go through the ear canal. So there's no cuts on the outside of the ear. There's no stitches. We make a very teeny tiny hole in the eardrum. We suck out all of that fluid because antibiotics can't get to it. And then we stick a tiny tube in that hole of the eardrum. It's nothing that you can see from the outside. You need what we call an otoscope to look in the ear and see it. And they're temporary. They last about a year. Sometimes they come out sooner. Sometimes they last a little bit longer, but it allows that ventilation. So it doesn't prevent the ear infection from happening because, like you said, it's a eustachian tube problem. It's anatomical, and it will take time to get better. But when they do get an ear infection, it doesn't build up that pressure. So you don't get the pain, you don't get the fevers, and the best part is it leaks out of the ear so mom and dad know. Oh, this is an ear infection. I see it.
Yep.
The kid is more comfortable. Parents are more comfortable. And the best benefit of all is ear drops are 1,000% more effective than oral antibiotics.
Yes.
They're tolerated a lot better. And so if your kid needs tubes, I know we're talking about surgery here, but it is truly a pretty benign thing and certainly something that helps these kids. So
it's remarkable how quick it is, how well the children do, how nicely they come out of it. And then quality of life change afterwards. So if it's needed, I'd strongly recommend it. For kids who are having learning challenges or those speech challenges, if that's associated with ear infections, or if we start to see every time we see your child, there's a big pocket of fluid, even if it's not causing them discomfort, but for a long, long time, and their speech is not quite coming along, that's also a really good reason we'll send them to you all to have a conversation. There's a critical time frame in which kids can acquire language and acquire the signals to produce language, and we need to get them hearing and speaking at the right time.
We've covered a lot of ground here, Dr. Krish. I'm so glad that you're here. We're going to take a quick break, and when we come back, we're going to talk about sore throats and coughs and other fun things.
When Hennepin Healthcare says we're here for life, they mean here for you, your life, and all that it brings. Hennepin Healthcare has a hospital, HCMC, and a network of clinics both downtown and across the West Metro. They provide all the primary care and specialty care you would expect to find. But did you know they also have services like acupuncture and chiropractic care available at many of their primary care clinics and at their integrative health clinic in downtown Minneapolis? Learn more at hennepinhealthcare.org. Hennepin Healthcare is here for you and here for life.
Welcome back. Let's talk about sore throats, Dr. Krish, specifically strep throat, something you see a lot of, I see a lot of. Tell me, when should a parent bring their child in for a sore throat? When do you test for strep? When do you give antibiotics? What should people know about this?
Yeah, thanks, Megan. And yeah, we see a lot of sore throats. I'll say, first of all, any child under 3 months who has a fever, you need to get seen. And I just want to throw that out all the time because if you have a small baby who has a fever, they just need to get seen.
Yeah.
But my general rule of thumb on other types of fevers for our older kids is if you're having more than a couple days of fever with a temperature of 101 or more, come see us. We'll check your ears, we'll check your throat, we'll check your lungs. Those are common places that bacteria like to hide, and we'd like to treat that if possible. And so then people come in and they've had these symptoms, and I'll still say the vast majority of times you have a sore throat, it's a virus.
Yep.
And I know folks don't love hearing that because there's not a cure-all for that. But the vast majority of the germs that will cause you to have a sore throat are viruses. Mm-hmm. But sometimes it is a bacteria. Right. And when is that? And what do we look for? We look to see if you've had a fever, like a legitimate fever, 100.4 or higher. We look to see if your neck has any swelling, if you have any what we call lymph nodes, right? Places where we know that we're fighting that infection. Third thing, and this is one that parents can identify on their own. Ask if you can get your child to open up their mouth big and stick their tongue out, you may be able to see white spots. And that is what we call, that's pus on the throat. And you sometimes can see that. And then this is an interesting one. Strep throat is more likely when you don't have a cough. Mm-hmm. A lot of families will come in and say, I have this sore throat and cough. Most often, that actually is a virus because it's causing multi-systems to be inflamed. But if you have strep throat's pretty good at not causing a cough, causing the pain to be right in that throat area and in those
tonsils.
That's right.
Yep. So when do you send these kids with strep throat to us in ENT?
So the nice thing is, if we see those symptoms, we can swab a child right there. We can get you an answer very
and they
quickly.
Love that too, right?
They love it. It's their favorite thing
They're lining up
ever.
at the door.
Yes. They're very happy with me afterwards. But we can get you an answer pretty quickly. We can get you the antibiotics if that's the case. We can treat you. We can make you feel better real quick. I will say Tylenol and ibuprofen in those settings can do a wonder, no matter what the sore throat is, can make things feel better. We swab you, you're positive, and then 3 weeks later, you come back again. And then a few weeks later, again, you come back with strep throat. Once we start to see that recurrent pattern, and the number is fairly high. Technically, it's 7 infections in a year. But once I start to see that pattern over and over again, Megan, I'm asking them to call you.
Yeah.
Almost in anticipation. They're going to get one more. Yeah. They're going to come see you. And then you guys can make an informed decision about taking out tonsils, keeping them in. I'll say, Megan, it seems to me like when we were younger, they took out a lot more tonsils.
Yes,
we're getting a lot more conservative about when we take out tonsils, weighing out the benefits of surgery versus treatment. And I think that's a really smart conversation to be had. There's some other things that may cause us to send them to you. For example, we have some kids who a family will say they snore like crazy. In fact, they pause breathing for 10 seconds. If we see that pattern, we may have them come see you because we're worried about obstructive sleep apnea. So there's a few other things, but I would say the number one reason that we send them to you is they keep getting strep infections over and over again.
Yeah. Again, 7 is not arbitrary. That is what our Academy guidelines recommend. 7 sore throats in 1 year. Doesn't actually have to be strep. And so those viruses may count, but the tonsils have to be big, red, ugly, kids miserable, missing tons of school. If a parent comes in, swollen lymph nodes, like you said, parent comes in and tells me all of this, it's pretty much a no-brainer. We should talk about taking the tonsils out. I'll say just a few things about tonsil surgery. It is also something we do all the time. It's very routine. It is a little bit more risky than putting in ear tubes. It takes a little bit longer. If you were to come to see me, we would have a whole long conversation about what surgery entails if the child has to stay at night, which if we're worried about sleep apnea, apnea, we will typically keep them overnight. If they go home the same day, they are going to have a really bad sore throat. It can take up to 2 weeks. This is not to be said lightly. However, kids tend to bounce back really quickly. It's better to do it when they're younger, under 12, and it does make a difference. It requires a conversation and really making sure that that's the right thing for the child because it is a surgery. So we're always happy to see those kids.
I think it's really great when they can come in knowing their lived experience, knowing how frustrating this process is, but have a conversation about the risks and benefits. And I think you all do such a nice job of laying those out for families.
Yeah. If you want to keep them, by all means, you can keep your tonsils. Years and years ago, older generation than you and I, they took out everybody's tonsils. It was like somebody in their 50s and 60s doesn't have their tonsils. The pendulum swung the other way. Nobody got them out. And now we have these lovely guidelines, which is super helpful. So let's switch gears to cough. We're going to wrap up with this topic. And so I kind of want to focus on two things, croup and RSV. We already mentioned the quademic in the beginning of the show with RSV, but croup happens. I mean, both of my kids had croup and it's scary. And so tell me, let's talk about the symptoms of croup, what you guys do for croup.
Yeah. So coughs are everywhere. And if you walk through any daycare or school in America, you will hear coughs left and right, especially right now. So we see a lot of patients with coughs, and there's a lot of things that can cause coughs. Back to this idea that you can have viruses, you can have allergies, you can have bacteria. And so part of our conversation that we're going to have with you and your family when you come in is what could be causing this. The most common things to cause cough, once again, are viruses, things like RSV and croup. Croup is a specific type of cough. It's a specific sound of a cough. We equate it to a barking cough, and we equate it to a barking seal cough. And when you hear it, you will know. I encourage everyone, go on YouTube right now and Google what a barking cough sounds like. You're going to hear it. And it's not actually, croup is actually not a diagnosis of a specific germ. It means that a specific part of your airway is inflamed.
Yeah.
And so you can actually have RSV cause croup. You can have parainfluenza, which is the most common one. You can have a lot of different germs cause a croup, but it means that a certain part of your body is inflamed, and that's why you have this funny sounding cough. And so it gets to be a scary thing because it's a scary sounding cough.
Yeah.
It's harsh. It's different sounding.
They can wheeze, right?
You can hear all sorts of sounds.
Yeah.
So kids will have this cough. And then I think it also gets scary because kids will often tell you that I'm having a difficult time breathing and it's challenging. And anytime a child says that, I mean, that's worthy
panic.
of... Yeah, no, and I wouldn't say panic, but I would say take it seriously.
Yeah.
Like let's address it. This is the time to do something about it.
This isn't, oh, Mom, my tummy hurts and I don't want to go to school today.
That's exactly right. When if someone says they're having difficulty breathing anytime, I think it's worthy of our full attention. So the nice thing about croup, though, is like some of these other things, we know how to treat it. We know how to make kids feel better. We have specific medicines, steroids, Decadron, that will make things feel better. And if we need to treat it more aggressively than that, whether it's in the hospital or the emergency room, we can. We have other medicines. There's also some things families can do at home. And this is actually something that I would say for any type of cough. I would say give your child 2 warm steam baths a day. So steam up the bathroom with a hot shower, make it nice and steamy, and let them sit there and breathe that warm air.
Yeah.
That can be very helpful and calming for them. My big advice around coughs, generally speaking, is this. 1, if someone tells you they're having difficulty breathing, take it seriously. 2, if you see ribs when a child is breathing, you need to get seen quickly. So I just watch a child breathe for a minute, watch my children breathe for a minute. If you can see those ribs tugging, come in.
Bad
if you can
sign.
see a child breathing too fast, faster than they normally breathe for prolonged periods of time, bring them in. No one's ever going to fault you for that. We want to see them. We want to evaluate. And we probably have some intervention that's going to make them feel better.
Yeah, and you mentioned the steroids. I mean, steroids for this, I think, do wonders, and I've seen it in my own children as well. From an ENT perspective on croup, the only thing that I'll say, and you of course know this, is a kid really shouldn't be getting croup all that much, right? That part of that airway should not be continually getting infected and inflamed over and over again. And so, we always say you're allowed to have croup once or twice. If you're having croup more than 2 times in a year, it could be an indication of some anatomical deformity, and that would be an indication to come and see ENT. And we have some nice little cameras and tools that we can do to get a good look down there, make sure everything looks okay. But we'll look for any narrowing of the airway or floppy airway or cysts or clefts or any of those other rare but important things to know about. So
absolutely. And yeah, if we see that pattern over and over again, we're definitely calling you all. I'll just say about RSV, it's in the news, it's everywhere. RSV, like group, will cause you to have a cough. It's just really prominent in little babies. Mm-hmm. Little babies will get it. And if little babies under a year or under 6 months in particular get RSV, back to our whole principle of a lot of mucus produced by these viruses in small airways can cause a difficult time breathing. And so that's when we see sort of the biggest problems. That's why it's really important to wash your hands and take care and not be around babies when you're sick, because you don't want them to get that level of mucus in their lungs.
Right. Exactly. Really great advice. Well, Dr. Krish, I can't thank you enough for being here and sharing your wisdom. You are a wealth of knowledge, and I am so happy to have you here at Hennepin taking care of my kids and all of our kids in the community. The pediatrics department here is just unbelievable. Just a pool of amazing, amazing practitioners. So thank you so much.
Thank you, Megan, and we're super grateful to have you there to support our children.
Thank you, everyone. Thanks for listening. If Dr. Hilden isn't here in 2 weeks, it's because he lost his job. We'll be back in 2 weeks no matter what. And in the meantime, be healthy and be well.
Thanks for listening to the Healthy Matters podcast with Dr. David Hilden. To find out more about the Healthy Matters podcast or browse the archive, visit healthymatters.org. Got a question or a comment for the show? Email us at healthymatters@hcmed.org or call 612-873-TALK. There's also a link in the show notes. The Healthy Matters podcast is made possible by Hennepin Healthcare in Minneapolis, Minnesota, and engineered and produced by John Lucas at Highball. Executive producers are Jonathan Comito and Christine Hill. Please remember, we can only give general medical advice during this program, and every case is unique. We urge you to consult with your physician if you have a more serious or pressing health concern. Until next time, be healthy and be well.